Hello, everyone, and welcome to today's discussion, where we're focused on persistent challenge of angina and the path forward for better patient care. Angina, as many know, is more than just chest pain. It's a physical manifestation of the heart's inability to get enough oxygen-rich blood, which most often is due to narrowed coronary arteries. This pain, which can represent as pressure, heaviness, or even burning, affects millions each year and can dramatically impact the quality of life and overall cardiovascular risk. Despite using a range of therapies, from nitrates to beta blockers to revascularization, a significant number of patients continue to experience frequent episodes of angina. In fact, even after interventions such as stenting or bypass, many people report ongoing symptoms and reduced functional capacity. Studies have shown that tiredness, side effects, lack of efficacy prompt repeated changes in therapy, and more than half of current patients still experience episodes. This persistent burden calls for innovation, a drive beyond symptom management to treatment that actually modifies disease, tackles the underlying mechanism, and most importantly, restores the quality of life to our patients. With that background, I'd like to invite our speakers, Dr. Tim Garvey, who works in cardiovascular risk and metabolic disease and has shaped patient management for decades, and Dr. Don Smidgy, a pioneer cardiologist and founder of Coeurative, to introduce himself and share a brief perspective on why this topic matters so much in everyday clinical practice.
Well, thank you, Ankit. My name is Tim Garvey. I'm a professor at the University of Alabama at Birmingham. I'm an endocrinologist. I've been in academic practice my whole career. I've been, from a research perspective, interested in insulin resistance and diseases characterized by insulin resistance, which include, diabetes, obesity, and cardiovascular disease risk. And I'm principal investigator of our NIH-funded Diabetes Research Center, and I'm happy to be here and share my perspectives on what we're about today.
Thanks, Tim. My name is John Smidgy. I'm a cardiologist by training. I was in academic medicine in my first practice in the University of Texas, and then at Wake Forest Baptist Hospital in North Carolina. But since the last 25 years or so, I've been in private practice, developed the Roanoke Heart Institute in Roanoke. And when I came around to thinking about, well, what did I want to do when I grew up, I actually decided to put together the Coeurative Incorporated, which is devoted to the development of curative strategies for cardiovascular diseases, especially those involving hypoxic endothelial cells that can respond to various vasodilators of interest.
Thank you, Tim. Thank you, John. And so to kick off today, I really would invite anyone to jump into the thoughts, but could you share your perspective on how angina is being managed at present? What feels effective, and what are the pain points or some of the frustrations you may have? It's common to see patients who are doing all right, yet are still suffering, and it's important we kind of shine a light on these patients as struggles are ongoing.
Well, I'll take that one because if I have a clinic and I see about 10 patients, one or two of them are going to be patients who silently suffer with angina pectoris. And I think angina pectoris is something that we still define on a daily basis because it literally means strangling of the heart, but really it can be demonstrated in many symptoms such as nausea, generalized weakness, diminished exercise capacity, shortness of breath, and then of course chest pain, which is what you see in the movies. We have a lot of patients who come in, and they'll say, well, I don't have chest pain. And then I'll ask them, well, when was the last time you climbed a flight of steps? Oh, I don't do that because if I did that, I'd have chest pain, And this is something there. If you actually look at the number of people involved, there are 10 million Americans with angina pectoris. 2 million of them have daily or monthly events of chest pain that's truly overtly symptomatic. And I think more of them have this kind of silent phenomenon where they're dealing with a limitation of functional status. And we have a wide variety of drugs, most of which are classics. like nitrates, beta blockers, calcium channel blockers, antiplatelet drugs. Ranolazine was the last one newly developed. That was brought to the market about 20 years ago, and the expired as a product, a brand name product in 2019. And there are several other new strategies available, such as the gene therapies, transplant of mesenchymal cells, modifications of the myocardium in order to metabolize the glucose instead of fat and be more efficient in the setting of hypoxia. But we really don't have an adequate vasodilator, despite all the other therapies that are available, since they all have pretty significant side effects and problems.
Yeah, John, let me add to that. The patients that I see largely as an endocrinologist largely have metabolic syndrome, prediabetes, or overt diabetes, MASH, and these are all high, very potent cardiovascular disease risk factors. So many of my patients also have cardiovascular disease and have angina. And there is you mentioned the old classics, isosorbide, the long-acting nitrates, and that's been around for a long time. And those just don't always work, and patients it loses its effectiveness over time. The patients become refractory. And other therapies, beta blockers, calcium channel blockers, same there. We need all the arrows in our quiver we can manage, because every patient's different. And you mentioned the silent angina phenomena, which of course a lot of my patients with diabetes have. So we really have to be extra vigilant for hypoxia, myocardial hypoxia due to coronary artery disease in these patients. So I really think we need more and effective therapies, a greater option of therapies, and therapies which have a more long-lasting effect and can be effective in patients that I see with insulin resistance, which entails impaired production of nitric oxide, which is the main vasodilator in the coronary artery system, and contributes to angina in these patients.
That's actually a great point. And I was curious, maybe John, you can answer this first here, but you mentioned that 2 out of every 10 of your patients are angina, and how many of them have kind of gone through, let's call it a roulette of different drugs? And the side effect profile is quite large, and a lot of them are not directly vasodilators. So do you see a large gap there that's really sitting, and maybe we're treating with the wrong drugs, even though they're classics?
Well, yes, I think that we're doing the best we can. But what really surprises me is the lack of interest in this subject from the pharmaceutical industry in terms of developing new agents, given the deficit that I see in clinical practice. And that's the disconnect that's kind of surprising. At the same time, it's an opportunity, but clearly that's the disconnect that I see in every day. These patients, they seem to have, I guess if you look at the spectrum of therapies available, sure, most of them have a stent. They've picked up some hardware, along the way. Some of them have had bypass surgery already, and their bypass grafts are going down slowly but surely as time goes on. A lot of mechanical methods and surgical methods are available to address these problems. I didn't really address those initially, but we know, for instance, that outside of an acute MI, coronary intervention with a stent or angioplasty has no impact on mortality, and barely has an impact on symptoms. And a lot of very expensive technologies have been put to bear without a whole lot of real serious results, when to me it seems like an augmented vasodilator regimen could make it not necessary, make all these many procedures unnecessary. Now that's the focus of a non-invasive cardiologist, of course, and we all tend to beat the nail with our own type of hammer, but I really think that there's an opportunity there that is unmet.
Well, John, I have the same impression. We have our classics that you've mentioned that have been around for a while, and other than ranolazine, we really haven't had new medicines to address this issue. And I've wondered why pharma hasn't been more active in developing medications and filling this obvious clinical need. And I mentioned we need all the arrows in the quiver we can get. So, maybe they just think with revascularization and these old go-tos that it's done. We don't need it anymore. But I can tell you, we do need more and better anti-anginal agents.
Well, there's a lot of money spent, and sometimes if you build a new heart hospital and build 8 cath labs, it seems like you're really making progress. And the people go in there and they have something implanted, and the placebo effect is tremendous. Well, I must be feeling better because I just had my artery deformed with a slinky. But then again, they'll be coming back with the same complaints in a few months, almost certainly. And it's not quite so bad as to cause them to go back to the hospital. So you look upon it as a success, but then they start having this sense of not being able to do the stuff that they used to do. Again,
I can tell you're a non-invasive cardiologist, John.
I was about to say,
I've never heard a stent referred to as a slinky, but I got that image in my head now.
Yeah. Keep thinking it.
Would you say the current interventions then that are medicinal really are not prolonging time to intervention, and we're just kind of in this endless cycle of trying, but we're really favoring more intervention, which is not prolonging anybody's or even curing anybody's pain. We're just kind of letting them go and kind of in the process.
Because ischemic cardiomyopathy is really endless. Once you start down the road, you can postpone the inevitable. But to bring the patient back to a full level of function, that's what I consider to be curative. To have them functionally satisfactory. You're not going to stop atherosclerosis. You can certainly retard it, but you can't stop it. So I think functional response is really important, and I think that's one of the things that's underestimated. The angiographic response to a mechanical intervention is not always the same as the true functional response, especially when you showered the artery and the resistance vessels with debris as you open the stent and deform the artery and break the calcium loose. So
I think function is really important because that's really is tied to quality of life, and that's what really our patients are interested in. That's what we're interested in. And my patients, it's not only ischemic cardiomyopathy, but it's a metabolic cardiomyopathy as well. This most manifests with congestive heart failure with preserved ejection fraction, but this impaired myocardial function in the context of insulin resistance is also present with reduced ejection fraction congestive heart failure. And a lot of my patients have congestive heart failure, and that, of course, impairs function and is attended to by symptomatology that impairs quality of life. So we need to protect the myocardium at all costs in these patients and make sure there's good blood flow and try to make the myocardium as healthy as possible from a metabolic perspective.
Do you think the also process that John is speaking of really restoring the ability to have a normal life also decreases overall risk on the metabolic side because they're actually able to, hopefully with certain changes in lifestyle, actually decrease their other syndromes as well, whether it be diabetes, peripheral artery disease, or so forth?
These patients have what's called cardiometabolic disease. So that's a single disease process that produces both metabolic problems, diabetes, MASH, dyslipidemia, and cardiovascular problems, coronary artery disease, congestive heart failure, peripheral artery disease. And so we need to think about all of these things in single patients, and we need to be ready. We know that patients with any one of these outcomes is at risk of the other one. So we have to be very vigilant and be ready and not be lethargic in terms of bringing treatment to the table, and also be thinking about prevention as well.
Absolutely. I think that's where much of what everybody's looking towards right now is how do we look at more preventative medicine? How do we see the actual ability to change quality of life and not just keep on bringing people back and forth through different processes, which have the same result. So, John, you kind of alluded to some of the new innovations that are coming out. Some of them seem a little pie in the sky or a little bit, let's call it, would be very expensive for most patients that are in this group. Would you be able to speak a little bit more on that, as well as I know you've been working very hard on a new asset, and that could be very, very promising within the field. I've been able to look at some of the preclinical studies, and it's very promising, but would love to hear more from you directly.
Sure. Well, clearly there are these options to do gene therapy and to transplant cells and to change the biochemistry of the heart, all of which are associated with very concerning long-term phenomena and uncertain outcomes. I think maybe, keep it simple might be a better approach, and to go back to a variation on the nitrates, the nitrate therapeutic option with something that will increase the duration of activity and modify the time course, so you get a more long-lasting approach. And I think the way to do that is to not only dilate the artery directly with a nitrate group and NO delivery directly, like you do in isosorbide mononitrate, but also to change the endothelial cell so that it creates nitric oxide with a glycolamide moiety that's attached to the drug that we're developing at Coeurative called CR0305. And 305 is a very exciting compound that I designed, literally on the back of an envelope, but also I with the help of some in silico techniques to have this dual effect. So on the one hand, it functions like isosorbide mononitrate in donating a nitric oxide. Nitric oxide producer is a nitrate group that produces nitric oxide in the cell. But then on the other hand, it also lends this glycolamide moiety. And I won't go into the biochemistry in detail, but there are plenty of references that will help with this. It reroutes arginine metabolism to the production of nitric oxide rather than the production of urea. So through this mechanism, the cell itself is making nitric oxide, overcoming some of the problems with tachyphylaxis. To my mind, the truth will come out in the clinical trials, but I think that we have a compound that has a lot of potential there, and we have in vitro data in human coronary artery cells to suggest that the effect of increased nitric oxide formation in hypoxia or relatively low oxygen environments is sustained over time, because first we see nitric oxide production over 4 hours, then we see cyclic GMP production over 16 hours at the peak. So we're looking at a 24-hour effect from this drug.
Let me tell you what I like about this mechanism of 305 in the patients that I see. So my patients are, have prediabetes, metabolic syndrome, diabetes, right? So, and obesity. And insulin resistance is at the core of these problems. And what happens with insulin resistance? Insulin is a major vasodilatory hormone, and it acts by increasing the activity of nitric oxide synthase, which increases nitric oxide. That lends to increased cyclic GMP formation, which further accentuates the vasodilatory properties, and also itself has antiplatelet effects and increases glucose uptake. So all of these are good effects. With insulin resistance, all of that is impaired. It's all knocked out. And insulin is nowhere near as able to mediate these salutary effects. So what does 305 do? It kind of bypasses these defects. It's a direct nitric oxide donor. So the nitric oxide is there. It has the substrate that allows the cell to make its own nitric oxide and to accentuate its production. And I think John has showed in ex vivo systems that it's also associated with increased cyclic GMP formation. So you're like addressing the major issue that's at work in these patients. And when you consider metabolic syndrome, prediabetes, diabetes, that triad, if you will, that's the majority of patients with coronary artery disease. Okay.
Absolutely.
You go into a cardio where you go to where they're doing a lot of stents and a lot of procedures, and go into the waiting room. You'll probably 70-80% of those patients will have either have diabetes or metabolic syndrome or prediabetes. So this is the issue, and I think very common. And I think 305 is really well designed to address this problem of angina in these patients.
These patients tend to go hand in hand from both your respective fields. I'm from a small town in Indiana, but it's known to be in the top 5 most obese cities in the U.S. And the cardiologists there come from far and wide, actually, to practice. And it's A, because it's liver, and B, you do see the direct need from one to the other. So I think it does make a lot of sense here that a new approach is needed. And as we wrap up, I just want to highlight a few threads from our conversation here. It's clear that angina care is still falling short just for too many, and the need for therapies that offer both symptom relief and deeper disease modification is urgent. I think we've spoken about some of the other things that are on the horizon, but we also know from the news things like gene therapy have actually led to recent deaths, and there is a trade-off here that isn't maybe supported for the masses. I think that something like 305 has the potential to positively disrupt our treatment algorithms. So on that, I'd really thank you both truly for your time, expertise, and candor. Let's keep the big questions and supporting each other as new data emerges, our practice evolve. I look forward to continued collaboration and learning from you guys. And thank you very much once again. Have a wonderful day, and let's continue to make meaningful changes in medicine.